Okay, what I'd like to do first is to acknowledge the land where I am in Sydney is land that that was the First Nations people of this country. It was Gadigal and Wongal country, and they lived in the whole southern side of the Sydney Basin. So I'd like to pay my respects to elders past, present, and future, and also pay my respects to any Aboriginal or Torres Strait Islander people that are listening tonight. So I'll introduce myself a little bit before I start. So I'm Simone Dorsch, obviously. I work at the Australian Catholic University in Sydney here, and I'm a director and a presenter with the StrokeEd collaboration. I've got to say that properly. What are we going to cover this evening in Sydney? We're going to talk about how extensive is loss of strength after stroke, what causes loss of strength after stroke, how does it affect people's ability to do things. In terms of intervention, what does the evidence tell us that we can do, and particularly looking at what does the evidence tell us we can do with muscles that are very weak after stroke, which is probably our hardest job, I think, when we're working with stroke survivors. And what can we do with people that don't have severe weakness but still have weak muscles? What can we do to help increase strength in those muscles? So looking first at loss of strength after stroke. So in studies that have looked at the lower limb late after stroke, the strength that's measured in the affected leg generally is less than 50% of the strength of age-matched controls. So we're seeing a very significant loss of strength in the affected leg after stroke. This is a study that I did, and what I did in this study was I looked at 60 people who had had a stroke. They were people that could walk for 10 meters, so that they weren't most severely disabled people, and I measured the strength of all of the major muscle groups of their affected leg, and also measured those muscle groups in 35 age-matched controls. And so what these bars represent is the percentage strength that the stroke survivors had in those muscle groups, where 100% is the strength of those muscle groups in the age-matched controls. So in the stroke survivors, the strength of their affected leg, you can see they've got really extensive loss of strength in all of the major muscle groups of their affected leg. And if you were to summarize it roughly, you would say that really the strength of their affected leg is sitting under 60% across all the major muscle groups, with some of those major muscle groups being much more like 40% of the strength of the age-matched controls. So very, very extensive loss of strength. What do we see early after stroke? So this is a very recent study done in the UK, and they've taken this data from the NIHSS data, and they've looked at people that have been admitted to hospital and been in hospital for at least 72 hours. So which means that when we look at this data, we're probably maybe not including the people with TIAs or very mild stroke. But in these people, what you can see if you have a look at the loss of strength in the arms, in the yellow, and in the legs, in the blue, that in this group, you're seeing, so almost roughly 35%, somewhere between 30 and 35% of those people having loss of strength in either arm or either leg. And obviously, generally them having, loss of strength in both arm and leg on the same side. So again, very, very extensive in the numbers of people that are affected. This is a study that looks at all people admitted with stroke, and quite a large group of people, and the amount of leg weakness that's seen in those people. And so in this study, because it's all people that are admitted with stroke, we're probably actually maybe including people with TIAs and mild stroke as well. And so if we start at the bottom, you could almost group this as like roughly a third of people who have no loss of strength, a bit over a third that have a mild to moderate paresis, and roughly 30% that have a severe loss of strength. So, so we're getting close to a third of people with a severe loss of strength. So that's, and we know this, I guess, that the percentages are very high of people with very significant loss of strength. This study looked again at all people admitted with stroke and looked at upper limb weakness. So severe, again, in almost 30%, mild, moderate in roughly 30%, and no paresis in just over 40%. So we're sort of still sitting around somewhere around that, almost close to a third there of very severe, almost close to a third of sort of a mild, moderate loss of strength. I'm going to talk a little bit about the leg and the trunk muscles. And the reason I'm going to talk to this a little bit is because historically people have spent a lot of time worrying about the trunk muscles. And in fact, after stroke, the trunk muscles are not nearly as affected as the leg or the arm muscles. So if we think back to those studies looking at leg muscle strength, we get generally it was sort of somewhere in the order of less than 50% of the strength of age-matched controls. Trunk muscle strength, these are the kind of results we see when trunk muscles are measured, that there is some loss of strength, but it's not nearly as much as what we see in the leg muscles. And there's actually a really good reason for that. And the really good reason for that is we have much better innervation of our trunk muscles. So we actually have bilateral innervation of our trunk muscles. So these are the muscles that are in fact most protected when we have unilateral damage in our brain. So this study, what was done in this study was people did a stimulation of the left motor cortex and then recorded a motor evoked potential in muscles. And the muscles that they looked at were the rectus abdominis and flexor digitorum indicis. And so if you have a look at this graph, this is what happens when you stimulate the left motor cortex. So you're stimulating just the left motor cortex, and what you can see here is that you see the same response in both sides of rectus abdominis. Okay, so that stimulation of the left motor cortex, because of the bilateral innervation, you get the same response both sides of your trunk. But what happens when you measure the results in the finger? If you have a look, you stimulate your left motor cortex, no response at all in your left flexor digitorum indicis, and what you would expect to see in your right flexor digitorum indicis. So yeah, trunk muscles are well protected compared to other things. Come back next week and listen to Carl tell us a lot more about trunk muscles. But the message here is, worry about the arm and leg, not the trunk. Okay, so a quick summary there. Early after stroke, including people with mild stroke, we're seeing somewhere in the order of 2/3 of people having some significant loss of strength. But in about 1/3 of people presenting with stroke, we're seeing severe loss of strength in the arm, probably, and the leg, if you sort of group people together. Late after stroke, in people that remain with that have some disability, they still on measurement have very significant loss of strength compared to age-matched controls. In the leg, it's really extensive across all of the major leg muscles. Loss of strength is there is some, but it is much less significant in trunk muscles. Any questions? Are there any juicy questions, Carl and Annie, that we should talk about?
Nothing so far, Simone, now.
Okay, I'll keep going. Okay, so what's going on here? What are the causes behind loss of strength? And there's the very, very obvious one, that you have lost upper motor neurons because of the damage to the brain. But then there's a whole host of other things that happen. So we see degeneration of the lower motor neurons because they're not getting their normal input. We also see a loss of excitability, a loss of the orderly recruitment that we normally have within our recruitment of motor units, slower firing rates. So there's a whole host of things that happen at a neural level that cause loss of strength. And what this is called is activation failure. So I'm just going to explain how this is measured so that the following slides make sense. So what happens when you're measuring the true capacity of a muscle is, as this study is done, that's called interpolated twitch. And so, for example, and I have had this done, so I can explain it. So if we were having a look at to see what was the force producing capacity of my biceps. Okay, so we would set me up in some sort of device that's got some sort of dynamometer device, and we would have a look at and measure the maximum voluntary contraction of my biceps. Okay, and that would give us however many newtons or whatever. What you do with interpolated twitch is you've got my MVC, and now you do this interpolated twitch, which is this really powerful stimulation that recruits every motor unit in my biceps, and you see the force that's measured from that. And then what you do is you compare my MVC to the force that was produced when the interpolated twitch was used. And generally, what you're measuring, what my MVC, the percentage of my MVC of the true capacity that was measured on the interpolated twitch, that's called activation capacity. And if I'm neurologically intact and everything, you'd expect my activation capacity to be somewhere in the order of 95%. So my MVC would have measured about 95% of what the interpolated twitch measured. And the interpolated twitch is really the true force producing capacity of my biceps. So activation capacity is the proportion that I can produce, which will be about 95% because I don't have any neurological problems. Activation failure, my activation failure then would be 5%. That's the 5% that I'm not getting. So what happens after stroke is very, very significant amounts of activation failure. So if we have a look, and here it's being presented again as activation capacity. These people have been measured 3 to 4 months after their stroke, and they've looked at a control group. So the control group have measured their activation capacity 94%. So that's sort of what you expect in people who are neurologically intact. Then they've measured the intact leg of the stroke survivors, and even their intact leg has got an activation failure of 25%. So even their intact leg, that person is not accessing, not getting the neural input to access all the force producing capacity of that intact leg. But the affected leg is much worse. So it's in the order of about 60% activation capacity, so about 40% activation failure. And then more than a year after stroke, it generally has improved, but this is in the knee extensors. So in the knee extensors, the measurement here a year after stroke, it still is away from, and the intact leg, you can see the intact leg is up at normal levels. There still is some significant activation failure, but it's much better in the knee extensors at 1 year after stroke in this group. This is a different study. There's not a huge amount of studies of this, unfortunately, but this is a different study looking at the ankle plantar flexors. And in the ankle plantar flexors in this group, who were 2 to 4 years after their stroke, their activation capacity is about 50-50. So there's still a lot of strength of that muscle group that they're not able to recruit because of that loss of neural input to that muscle. So generally it's thought that activation failure is a much greater contribution than the secondary changes, the peripheral changes such as muscle atrophy. Though of course, you're going to end up, particularly if you're quite disabled, you are going to end up with quite significant peripheral changes as well too. And you can see that in this group here that have been measured, and you can see they've measured the unaffected leg. This is the medial gastrocs in the unaffected leg, and that's the medial gastrocs in the affected leg. So you can see very significant atrophy there. Okay, so I might just keep on going, talk about strength and activity, or stop here, Carl and Annie? I can see there's a few Q&As there.
Yeah, so is the initial loss of strength in the intact leg due to secondary deconditioning or neurological insult?
No, it's too early to be secondary deconditioning. It's been found really, really early after stroke. So it does seem to be that you seem to have lost some neurological input to your intact side as well.
Okay.
Yeah.
Second question, does strengthening of the quads, open chain, translate to reduced hyperextension in stance, or does this need to be trained functionally?
Yeah, well, yes, you would need to train it functionally is I would answer to that, because hyperextension isn't only about your quads as well too. So I think, people will often hyperextend just to make their leg more stable because they have significant weakness in their quads. But when you think about controlling that inner range of knee extension, there's contributions from your plantar flexors and your hamstrings, as well as from your quads. So I think that, at a level of coordination, you're going to need usually quite a lot of task-specific training to work on people's coordination to control that inner range of knee extension.
And somebody's asking if you can explain activation capacity a bit more.
Oh, I thought it was so beautiful, that explanation. So activation, so the things that are being measured, they're measured in that measurement that I explained with the interpolated twitch. You're measuring two things. One thing that you're measuring is my maximum voluntary contraction, the most force that I can produce from my biceps, my MVC, my maximum voluntary contraction. The other thing that you're measuring is the force produced from the interpolated twitch. And the interpolated twitch activates every single motor unit in my biceps. So the interpolated twitch is the maximum force that biceps can produce. And then the activation capacity is what did I produce? What did my voluntary contraction produce as a proportion of what is the total force production capacity produced from the interpolated twitch. So the activation capacity is, what's the proportion of the true strength producing capacity of that muscle, which is usually, as I said, neurologically intact. It'll be about 95%. So I would be able to, my maximum force would be about almost the same, but not quite, as that interpolated twitch. And that would be my activation capacity. And in stroke, that's measured obviously as being much, much lower. I hope that got it.
And there's a follow-on question from somebody else. Is that interpolated twitch a machine?
Yeah. It's a very, very strong electrical stimulation. So it's the kind of electrical stimulation that you don't go to people as training of any sort, kind of thing. I've actually been in a study. I've been a participant in a study, and it's quite uncomfortable. And I don't know the details about the type of stimulation that they're using, but it's an incredibly powerful electrical stimulation, so powerful that like I said, it gets every motor unit in that muscle. But they only need to do it for a second. So you get this absolute jolt through your muscle as every single motor unit contracts. But they've got all this kind of snazzy equipment so that they measure the force. So you get this, it's nasty. but if you get asked to be a participant in one of those studies, it's also extremely short. So but that's probably why there's not a whole lot of studies of this out there, because it's not a very nice thing to ask people to do. But yeah, incredibly powerful electrical stim, basically. Very different to the type of electrical stim that we're using when we're using it.
It's obviously quite interesting to people. And as I said to you last night, it was something I hadn't heard much about at all before now. Somebody else asking, do you have any figures for activation failure in the upper limb?
No, I don't. And I don't actually, like I say, I haven't been able to find a lot of studies that have measured this. And I actually can't find nearly as much detail about upper limb loss of strength as there is about the lower limb either. But if you find it, please let me know. I'd be fascinated to see what the results would be in the upper limb as well too, but I don't know of any.
That's all the questions for now, Simone.
Okay, so strength and activity, because really it's all about activity, isn't it? That's what we really want to know about. Okay, so first of all, I'm just going to explain this graph, because I think conceptually this is a really important concept, if you like. So this is what this graph represents, is the relationship between strength here on the x-axis and activity on the y-axis. And so what you can see here is that if you have very low levels of strength, you have pretty much a linear relationship, a direct relationship between strength and activity. So in weak populations, which is sort of really this group here, there's that kind of almost direct relationship. And so what that kind of means is that if you want to boost things up on the activity side here, that really doesn't really happen unless you boost things along the strength continuum, if you like, because you've got this really direct relationship here. But what you see in where people have sort of normal amounts of strength is that relationship is gone. Okay, so if you're thinking, I think maybe a nice way to think about this, mind you, not nice necessarily, but if you think about, particularly if you work with aged populations of people, so older people, and you have somebody who's been admitted to hospital because they've had a pneumonia or a nasty chest infection or something, they spend a week or two in bed. And then they go to get up and they can't get out of a chair and they can't walk properly and stuff. And so that loss of strength that's happened to them in that week or two that they've been inactive has really affected their performance at the level of activity. And it's because they're sitting somewhere here. And this relationship was at first just shown in older people. So it's because they're sitting at a very critical part of the graph where any movement down the strength continuum will move them from here down to here. And maybe that from here down to here has mean they can't get out of a chair and they can't walk properly anymore. Now compare that to you or I, assuming that you out there have normal amounts of strength. If we were to spend a week or two in bed, we're up here somewhere. So if we spend a week or two in bed, maybe we do lose strength a little bit. Maybe we move from here down to here. But if we move from here down to here, that has not changed our performance at the level of activity. Okay, so I think this is a really nice, well, it's a kind of a fairly well established relationship, but I think it really helps to explain what's going on here. So when you think about the context of people who have had a stroke, as we have seen, they've got very extensive loss of strength. So they're really sort of sitting down here. So that generally, if they're very disabled and with significant loss of strength, you really need to change levels of strength in order to change performance at the level of activity. What we have here is studies that have measured correlations between strength, muscle strength, and performance at the level of activity. So looking here at sit to stand, standing, stairs, and arm function. And I'm going to talk about walking in much more detail because I've got more information about that. But what we're reporting here is correlations. So remember, so this is, Pearson's correlations values, or Spearman's, however they were done. But remember, if you remember this is an R value. So where 0 means that there's no correlation, 1 means a perfect correlation. So 0.5 is pretty significant. So this is the correlation between leg strength and sit to stand performance, the correlation between leg strength and standing balance performance, the correlation between leg strength and stairs performance. You see some very high values there. Correlation between arm strength and arm function, some very, very high values there. So we see these very high correlations in stroke, in the studies that have been done of stroke survivors, because they are right down at that end of the graph, where there is that really significant relationship between their strength and their performance at the level of activity, because they have very low levels of strength. Now, I have a systematic review that is currently being published in Physical Therapy. So just sent back the proofs. So literally is very hot off the press, well, not quite hot off the press, about to be hot off the press. And so what we did in this systematic review was we found all the studies that we could find that measured correlations between the strength of the affected leg after stroke and people's walking speed. So really interested in exploring that relationship between how strong your affected leg is and how that's sort of associated with your walking performance. So we found 30 studies. We averaged all the correlations from all the muscles of the affected leg, that had been measured, and the average across all of them was a correlation of 0.51. So pretty significant correlation between strength of the affected leg and walking speed, and the 95% confidence interval 0.45 to 0.57. And that just means that we can be 95% confident that that true value lies between there and there. So they're pretty tight 95% confidence intervals, which means it's because we had such a large body of data that we really can be very confident that that value really does sit very closely around that 0.5. And this is what it looks like on the forest plot. So these are all the individual studies, those 30 studies that measured strength of the affected leg and walking speed. 0 here would be no correlation. 1 would be a perfect correlation. And you can see on average, when we pull them all together, we're sitting right in the middle there. So a pretty significant relationship there between strength of the affected leg and walking speed. Then what we did was we took all the studies that measured each of these muscle groups, and you can see the number of studies that we're able to include in that pooled analysis of data, and what was the average correlation. So this is the average correlation, so between hip flexors and walking speed, 0.47, and so down there. Now, I think the main message to get from this data is that the lowest is 0.42, the highest is 0.57. So there is not a lot of difference between the lowest correlation and the highest correlation of these individual muscles of their strength and walking speed. And I think what really that data is telling us is that all these muscles are important. And there's some researchers, myself included, who spend a bit of time saying, you have to really worry about the dorsiflexors, because I did a study where the dorsiflexors looked very important. But that was one little study, and now we have these 30 all put together, well, whatever numbers that we've got for each of these muscles. And when you have a large amount of data, it's all kind of washing out. They actually are all looking pretty important. So the big message there is that they all seem to be, pretty important in their contribution towards walking speed. Now, the next thing that we looked at in this systematic review was we kind of looked at how the participants in each study, if you like, what was the average walking speed as an indication of how disabled they were, what was their average walking speed in each study, and how big was the correlation in that study between leg strength and walking speed. So I hope that makes sense. It's kind of a correlation of the correlation with the walking speed in that study. And I'll show you on a graph, which I think explains it a bit better. But what the average correlation is negative 0.7. So 0.7 is a very high correlation, and it's negative because it goes in the other direction, which I'll show you on the graph. Hopefully makes more sense. So what So this is a graph of those results. And so this is, as I said, this is the correlation between, for each study, the average walking speed of the stroke survivors in that study, and the correlation that they reported between strength and walking speed. So if you have a look here, so if you think about so if we take one of these studies where the walking speed was very low, so there was one of these studies where the walking speed of the stroke survivors was on average less than 0.2. That is very, very, very slow walking. The correlation between leg strength and walking speed in that study is 0.8. Okay, so what this is telling us is that at very low speeds, the correlations are much higher. If you have a look at the studies that are sitting up around much better walking speeds, so if you have a look at this study here, people are walking at 1 meter per second. 1 meter per second is not getting that far off normal walking speeds. Their correlation was 0.2. So very, very low correlation. So what this is telling us is that, the worse your walking is, the higher is that correlation between strength and walking speed. So in people who are more disabled in the context of their walking, have this much higher association between their leg strength and their walking speed, which makes strength look really, really important in those people that are more disabled. Okay, so let's summarize that whole strength activity story. After stroke, loss of strength, I haven't described the other impairments because that is a much, much bigger story as well. But loss of strength has a much greater impact on activity limitations than any of the other impairments. And if we do go in and have a look at the sizes of loss of sensation, loss of or spasticity, any of those other impairments, loss of strength has a much, much, much greater association with people's activity limitations. So it's paying a much greater contribution. Loss of coordination quite often has very high correlations, but not always. It depends a bit on what was measured and the people it was measured in. But when you think about it, without strength, you can't move. So without strength, you've got no movement. So kind of in some ways, your other impairments are all a bit irrelevant if you haven't even got enough strength to be able to move your arm or your leg. The relationships between loss of strength and activity are much greater in those people who are more disabled. So strengthening is more important in those people. When you think about walking, all the major leg muscles are showing up as having a pretty significant contribution to walking speed. So worry about them all. Lots of jobs to do. Strengthen all those muscles, basically. Okay.
We have one question. Can you predict who's going to get leg weakness? And maybe this is a question similar to the prediction that's been going on for the upper limb by the group in the Netherlands and in New Zealand.
Prediction is.
But I don't quite understand, because leg weakness is a direct result of the stroke. So you have leg weakness immediately as a result of the stroke. Mm. So maybe could that person clarify exactly?
Actually, the question is, can you predict whose strength will improve after stroke?
Okay, yeah.
Which is why I think it's a little bit like the what the New Zealand group are doing, trying to predict who will.
Yeah, I mean, I guess at a very sort of gross overall picture, you'd say the people that improve least are the people with worse loss of strength. And I think that's what we see clinically. The people that are very paralysed, that have grade 0s, 1s, it's much, much harder to change their strength than in somebody who already has grades 2s or 3s after their stroke. Because, the things that you can do for somebody who's got grades 2s or 3s are so much easier to set up and so much easier to get those muscles stronger. But if you have severe loss of strength, it's much, much harder. And so severe loss of strength is a poor predictor of outcome, or predicts a poor outcome. It's maybe a better way of saying that.
Mm. Okay, thanks. Another question, can you explain the effect of decreased strength in the non-affected limb post-stroke acutely in some more detail?
Well, I don't think that that loss of strength is significant enough to really see its impact on function. Because when you look at the measurements of it, generally where it's measured to be, and there are some studies where what they've done is they've measured the affected, well, I must admit I've only seen it in the leg again, but they've measured the affected leg, the intact leg, and then age-matched controls acutely after stroke. And what they're showing there is that the intact leg still looks weaker than the age-matched controls. But it's in the order of sort of maybe 80 or 90% of normal strength. And we think about that activation capacity what was that, about 75? So if you had fairly normal strength, before your stroke, and now you're down to 75 or 80% of normal strength, that's probably not enough of a loss of strength to really impact your function that much, unless you're really, really weak premorbidly, I guess. Yeah. I guess I'd be saying don't worry about it. I mean, it's there, but you've got so much to worry about with the affected limb. Don't worry too much about the intact, really.
Another question: are there studies that demonstrate emphasizing strengthening of muscles activated the most on stance phase of the gait cycle will improve walking ability? So are there studies that emphasize?
I don't know anybody that's really looked at that kind of level of sort of detail, and so what would you'd almost need a study where one group has strengthened their stance phase muscles and one group strengthened their swing phase muscles, and then who does better. And I don't know of anything like that. I think we need to have a look at the person in front of you and which muscles are weak, which muscles do they need to get stronger in, and if they dorsiflexors and their hip flexors are really weak, then that's really going to impact their swing phase and get them stronger. If they're really, really weak in their hip extensors and hip abductors and plantar flexors, then that's really going to impact their stance phase and get them stronger. So I think you probably just need to do that sort of clinical reasoning around the person that you're seeing.
Yeah. And now Carl's just answered one of the questions, which was, what does STS mean, which is sit to stand?
Oh, sorry. Yes.
All these abbreviations that we have.
Yes. Yep.
And here's a good question: why does loss of strength in the upper limb more often take a longer time to recover than the leg or the lower limb?
Yeah, that's an extremely good question.
We don't know, do we?
Do we? I think there's a lot of things going on there. I don't know that we really know, because there's those studies now where they look at sort of motor evoked potentials and try and establish whether there's still any corticospinal tract going through to the affected upper limb. And we don't really have that detail so much in the lower limb, because it's actually much harder to measure that stuff in the lower limb. We can't measure it as well, because it's all, the lower limb's deeper in your cortex, and you can't measure those things as well. I don't know that we really know this. I'd be interested to see what Carl says about this, but I think in some ways it's because we can force a leg to work in the way that we cannot force an arm to work.
Yeah.
You can you can sort of position people, and really with an environment set up, you can position them in a way where they're doing sort of sitting balance, sit to stand, standing balance, where you're really forcing muscles to start to work. And you can't do that. You can't really do that to an arm in the same way. And then if you were to have a look at the amount of time that is spent in rehabbing the leg compared to rehabbing the arm, then is there an issue there about amount of practice as well too. So I think there's just a lot of stuff going on there. It's much easier to get a leg started because you can force it to start in ways that you just can't do to an arm. We spend much more time on the leg, especially initially and early after stroke, where it's just important. Everybody's focused on getting people on their feet and helping them get out of hospital. Whether there's other stuff going on that's to do with the connections and things like that, I don't really know, and I don't actually know that we have that level of information.
Yeah, yeah.
Mm.
Carl's nodding, saying yes, he agrees with your reasoning there. Yeah. Somebody's asking whether you should focus on the weaker muscles first in strengthening.
Oh, well, it kind of makes sense too, but I mean, but I think the problem is that generally the people that we see have so many weak muscles. If they've got weak muscles, they tend to have a lot of weak muscles. So we are going to talk about that much more when we start to talk about intervention. I mean, I think we do make some decisions of convenience often, don't we? Particularly in the lower limb, where we probably really focus a lot on the extensors early, because you know, if people can't get their extensors working better, then they just can't stand and wait there on that leg. So I think in an ideal world you would focus on all weak muscles, but I think we often do make some judgment calls about what is really most important to help get this person up and moving. But I don't think that we should necessarily be making decisions that way, but that is what happens.
And certainly with the arm, if somebody can't lift their arm, they need to get shoulder muscles.
Yeah.
Flexors, external rotators to be able to contract, but they also need to be able to open their hand. So, you know, you're working between the hand and the shoulder and trying to get all those muscles working.
Yeah, I think, yes, I guess the question is, ideally you really want to work on them all.
Yeah. Two more questions. So they're coming in thick and fast. Somebody's attended your 1,000 reps a day workshop, which was amazing, and is just suggesting, does this information apply to manual muscle tests 0 to 2 rather than groups 3 to 5?
Can you hold that thought as we move ahead and see whether we answer it, because we're about to look at all that information and we're going to divide people up into those kind of groups.
Yeah. And somebody's sending best wishes from Malaysia and asking, what is the carryover effect or effectiveness of muscle strengthening post-stroke in the limbs which have only got manual muscle test 0 or 1, especially if it's somebody chronic, longer term after stroke?
Yeah. Listen, I think that we can make a difference to those muscles often, but I think it just takes the most extraordinary amount of work to make a difference to those muscles. And that really, if you're going to improve somebody at the level of function, then you know, then they're going to have to get up to much higher grades of muscle strength, really. Because I mean, if a muscle cannot even move against gravity, in some ways it's probably not that helpful to you at a functional level. So I think those muscles can be made stronger, but with the most enormous amounts of work.
Okay, that's all for now. You can carry on with the presentation.
Okay, so, well, there's a few people asking some questions about intervention, so that's where we are now. We're in intervention. Okay, so what I'd like you to do is think about what interventions you currently apply for muscles that are sort of paralysed or just got a flicker, so they're 0s to 1s. What do you do with people with that kind of level of muscle strength? With people with grade 2, so they can move but not against gravity. Grade 3 can move against gravity but not really against resistance. Grade 4 can move against resistance but, you know, still less than normal strength. And conceptually, is that a way that you think about the interventions that you use for increasing strength? I guess I'm kind of interested in that as well too. So just reflect on that. I'll give you 5 seconds. What I'm going to do now is to have a look at the evidence that we have for interventions that can be used at these different levels of strength. And then I'll bring this slide back up at the end, and you can see whether you've got new things to add to it. Hopefully we'll have some helpful information for you there. Okay, so thinking about muscles that are very weak, grades 0 to 2, what does the evidence tell us that are interventions that we can do to make a difference to these very weak muscles? So electrical stim, we have evidence for electrical stim. So in here we have an effect size of about 0.5. You can see this is the pooled analysis here in this systematic review. So 0.5, you can see it's like a statistical value, a standardized mean difference. 0.5 is considered a moderate effect size. It's hard to translate that back into a clinical effect, if you like, but certainly we do see an effect of plain cyclical electrical stimulation on strength. What I've pulled out here is just a bit more of a look at from some specific trials that are included in some of the systematic reviews that have been shown that really were quite effective. What were they doing? So these studies were doing EMG triggered electrical stim, and we don't really have any studies that really do, or not any significant ones that really compare EMG triggered to plain electrical stim, but it kind of makes sense when you think about what's going on here. We have a loss of strength that is mostly due to a lack of neural drive. So if your electrical stim is triggered electrical stim, whereby the stroke survivor has to try and produce some muscle activity before the electrical stim kicks in, then you would expect that that's going to have a greater effect. So not that we have the research that goes to that depth specifically, but these studies that did EMG triggered, so a machine that reads EMG activity, the person produces that threshold level, and then the electrical stimulation kicks in, have been shown to be quite effective. Therapist triggered. So those are the kind of machines that have a little like hand trigger kind of device. Newsom did it as like hand triggered electrical stim on quads during a weight shifting activity. Thrasher did a group of, a whole bunch of sort of different arm muscles, so the person had to attempt the movement, and then the therapist would trigger the machine after that attempted the movement. And these are studies that had some fairly impressive outcomes. But the other thing I'd like you to note is the length of time here. 45 minutes, 150, 60. They're probably a lot bigger dosages, I would imagine, than a lot of us are applying electrical stim for as well. And this one, that is the plain cyclical electrical stim, so just the standard on-off kind of machine, 90 minutes a day for 8 weeks. So they're large dosages, is what I'm saying. These studies that have shown, that have been really, have had quite impressive results. And what we are looking at here, and you'll see across all of these interventions where the evidence is telling us that they do really make a difference to strength, the common feature is the dosages are large. And so if we think about very weak muscles, loss of neural drive to those muscles, then what people need to be doing is very high amounts of practice. So if you're trying to increase neural drive, it's about neural plasticity. We're talking about, somebody mentioned the 1,000 reps workshop, we're talking about hundreds and hundreds and hundreds of repetitions here, really to get neural plasticity. And that would be the common feature across all of these interventions that the evidence is telling us can make a difference. So if you're thinking about electrical stim, and this is really just having a look again at thinking about making it as effective as possible, getting people, so even this is a plain cyclical electrical stim machine, but you can see the person set up, they've got a visual cue, so that while the electrical stim is working, they're really thinking about trying to extend their wrist with the machine. So if you've got a visual cue to get somebody's attention, then that hopefully then you're going to increase the neural drive. This person is sort of really doing a more functional electrical stim, so they're really thinking about using it to help them grasp the cup. This person is doing EMG triggered electrical stim. They haven't got it here, but there's a sort of a marker at the end of the table, so they're really thinking about trying to flex their shoulder to get to this mark on the table. So really thinking about the principles of sort of setting up practice, having visual cues and things that make it as engaging as possible within the context of the electrical stim to increase its effectiveness. Now, David D'Souza did a very large systematic review looking at the effect of repetitive practice on strength. So he's taken all studies that are looking at an intervention and where there has been change at the level of activity, and looking at what happens at the amounts of strength that are seen to be changed in those interventions. So I'm just going to flick to the next slide, because this is really that speaks to the ones that, again, thinking about those sort of grade 0 to 2 muscles. These are interventions that we can use in those muscles. So we know that robotics, and that's been used much more in the upper limb in the context of looking at strength, but we know that robotics can improve arm strength. Electrical stim can improve leg strength and this is where David has gone back and sort of back converted and to give us a percentage. So we've got like a bit of a more clinical value. Assistive technology, here the assistive technologies that were included in this analysis were SmartArm and SableFlex. I'll show you a picture in the next slide. And constraint-induced movement therapy. So constraint-induced movement therapy, most of those studies haven't measured strength, but in a couple of studies where they have measured strength, the changes in strength are really quite impressive. Now, again, the common features of all of these interventions is that they tend to all involve very high numbers of repetitions of practice. Okay, so we've got a theme here, I think, haven't we? You know, so high amounts of repetitive practice. And this is just to show you the interventions that sat under that umbrella of assistive technology. We've got the SmartArm device, so you've got this friction-free device here, so, and with some visual feedback for somebody with a very weak arm, and also could be applied with electrical stim as well. And this is just an image of the SableFlex, which I think a lot of people would be familiar with. The task-specific training, the studies that looked at task-specific training and measured leg strength also showed a significant improvement in leg strength, though the values aren't sort of quite so high. But there still is a significant effect of task-specific training. And so we're going to look at some examples of using task-specific training, but again, we're still sticking in those, you know, in those very, very weak muscles. So here, what we're thinking about here is how do we set up task-specific training that really tries to force a muscle to contract. And I think this is where we can do things much more with the lower limb than we can with the arm. So Carl is doing, and you can see, and the other thing that I think I'd point out here is that this lady, Lindy, is quite early after a very large stroke. And for her to do a lot of isolated muscle strengthening would probably be quite hard at the moment because her world is not making very much sense. So in fact, it might be much easier to really try and get more leg muscle work happening within the context of doing some task-specific practice, but she's being set up to practice in a way that's really going to start to force her right leg to work. So if we have a look at what she's doing here, so you can see this is her weak side. She's reaching across towards her weak side, and you can see that Carl is palpating her quads tendon to see how much she's using her leg. So what I might ask you to do is, if you can, I just need to push my chair backwards, if you're not so familiar with this as a form of training, is to push your chair back away from your table a bit. I'm just going to pause Lindy for a tick. Put your chair back away from your table and then reach towards your left, if you like, well beyond arm's length. Okay, maybe if you didn't start, bring your bottom forward so that you haven't got much thigh support. Bring your bottom to the edge of the chair, reach well beyond arm's length, and think about what muscles are working when you do that. Think about if you start to reach so far that you're almost about to fall, what muscles are working when you do that. So hopefully what you could really feel working a lot was your lower limb extensors. Okay, so if we have a look at Lindy reaching here, so when she reaches right across to the right, which is quite difficult for her, and then Carl's telling her to push herself back towards the wall, she really has to use her right leg muscles to do that. So we're really setting her up to do task-specific practice, setting her up to do it in a way that really is going to really force her right leg to work. And there is some good evidence here. So if you're interested in the evidence around this sitting balance practice, look up the studies by Kath Dean, in which she actually did measure EMG activity and show big changes in muscle activity with that training. And here you can see Carl working with a man called Keith, who's now doing some standing practice. But because of the environment set up here, this man is really being forced to use his right leg quite a lot. So his right side affected as well, his left side is against the wall. And because his intact side is against the wall like that, there's going to be a certain amount of weight really forced onto his right leg. So for him to stand and not fall away from the wall, he actually really needs to keep some activity in his right, particularly in his right knee extensors, probably to some extent in all his lower limb extensors, and also probably a little bit in his hip abductors as well. So that's really forcing his leg to work. And if you have a look at this man, again, very early after his stroke, his world is not making very much sense to him at all. But here he can do some very useful practice that's really forcing his right leg to work, basically. If you have a look now, you can see, and so that's why we're talking about the environment. The environment setup is critical to making this work. So now he has moved his left leg away from the wall, and you can see his right leg has become quite passive. Now he's just weight bearing on his left leg. His right leg's not doing much at all. So that environment setup is really critical to making that work properly. Okay, so we have some evidence also for mental practice. So there's a Cochrane review with a lot of trials looking at mental practice, and generally, in these trials, it's mental practice plus usual therapy compared to just usual therapy. And we see some really significant results for arm function. So an effect size of almost 0.7 is really, getting almost, 0.8 is considered a large effect size, so it's a really pretty significant result. Arm impairment measured with most of these studies use Fugel-Meyer, which is kind of general, so like arm movement. So it's a sort of, in very weak muscles, it does probably represent changes in strength, but it's also got other things being measured at the level of impairment, but again, an effect size of about 0.6. So mental practice can make a difference to strength that would certainly seen from these results. If we think about mental practice, it needs to be set up properly. So you kind of need to set it up the same way that you would set up physical practice. So you need to set it up as though you've got really a certain amount, a certain quantity of practice, that there's very specific details. So this is from a systematic review by Page. And so there's very specific details about what you're thinking about, what setting it, what are the sensations. So that mental practice, there's a lot of detail to it. And then you record it, you set it up as though the same way that you would set up physical practice in terms of really prescribing it to make sure that it really does actually happen. Mirror therapy, we also have a Cochrane systematic review looking at mirror therapy, and the comparisons were a bit more variable in this one. But from this Cochrane review, that it shows improvements in arm function, an effect size of about 0.5, so moderate effect size, and again about 0.5 for motor impairment. So, and if we have a look here, we see Annie working with Hong doing mirror therapy. So this is his intact side, and here you see here's his affected side, and so he's practicing thumb abduction, he's looking at his intact side but he's also moving his affected side. So we do have certainly some reasonable evidence for mirror therapy as well. And just a note that this video comes from a learning module that sits on the Australian Stroke Foundation's Inform Me website, which is Annie doing the kind of going through the clinical reasoning process of Hong's practice and doing mirror therapy with him, as well as some other practice. What else could help? And again, in the context of very weak muscles, some of the things that and this is not so much from research now, but some of the things that we know that we can try that sometimes do help is trying different types of muscle contractions. So Mary here is looking at this man doing an eccentric triceps contraction. And so the reason that is sometimes helpful is because sometimes because an eccentric contraction actually produces more force than a concentric contraction for the same amount of descending input. If you any kind of device that facilitates people being able to produce more movement is obviously going to be helpful in very weak muscles. And so this is a sliding tilt table. So if you haven't seen one of these before, what it is, it's like you think about your standard tilt table, this is all fixed, but in this one, the whole back of the tilt table can slide so that Mr. Lee here, who has a really weak leg, can really work on his knee extensors here. So you can see, and so he would not even score a grade 2 with his knee extensors at this point in time, but he can do lots. And remember, it's all about lots of practice. And here he is practicing with his daughter, and he can spend hours and hours and hours doing that. It's probably the most useful thing he could be doing at the moment. And again, thinking about the context of engaging people in doing lots of practice, if there's things that help to give them information. So this lady, Narelle, had a large stroke and she fractured her ankle when she had the stroke. So then she was non-weight bearing. So she spent a lot of time in bed and she had pretty much, zeros or ones in her quads to start with. She spent a lot of time just working on her quads in bed. So she's got a pressure biofeedback device. But you could use any sort of daggy old sphygmometer. Never let the nurses throw out old sphygmometers because they're fantastic for feedback. So you've just got some sort of device where when she pushes down on it, it gives her some visual feedback here. So this is her kind of looking at the visual feedback. And so when she pushes down with her knee extensors, her foot's fixed just to make it all a bit easier for her to think about pushing down into her foot. And she's getting some feedback about what she's doing. Any questions?
Yeah, there's a couple of questions here about mental practice, which I might respond to. Somebody's asking about how are there any tips and things that you can recommend related to mental practice? And a second person's asking about examples of task exercise setup for mental practice. In the upper limb workshop that we run online, we in the 3-part workshop, we talk about that in both workshops for people who've got very weak upper limbs and also people who've got more advanced hand coordination goals. So if you want to learn more about that, we've got examples that you can listen to and watch in that workshop for people with cutlery problems and very weak limbs. I don't know if you want to add anything about lower limb mental practice, Simone. I think that's something that's there's less written about mental practice.
Yes, I really don't know that literature very well, and I can't say that I particularly used it as an intervention, but I think we know a lot more about it in the upper limb.
Yeah. I mean, the one thing I will say, just to give you some tips now, a lot of the trials, there's lots of variability in the length of duration of sessions and how many sessions people get. What I tend to use when I'm working clinically with somebody is 1 repetition of attempts at reaching and 1 mental practice or rehearsal of that movement. The same thing if somebody's practicing picking up a pen or a knife and fork and they're not able to actually control the amount of force or pressure on a fork or a knife or a cup. So they might be doing 1 mental practice of the amount of force generation and then 1 physical practice, alternating between 1 and 1. So they're not having to concentrate for a long period of time, which is difficult for people. A question here, what minimum dose would you recommend for cyclical e-stim?
That's a very good question. If you have a look at the trials where people have got some, I guess, better looking results, they seem to be at least 30 minutes per muscle group, basically, and then if you're doing multiple muscle groups, that's kind of going to add up to quite a lot. which is why I think we need to really look at the context of electrical stim being done in semi-supervised or independent practice. So we teach stroke survivors and their families how to put the machines on, and it's not something that is taking up sort of one-to-one therapy time, but something that people can take away with them. Or you set them up to do it in a corner of the gym, and then they do it. And again, with some of those environment setup kind of things that we looked at to help make it as engaging as possible.
Another question about electrical stim is, were the studies that you reported on looking at consecutive 90-minute sessions, or 45, 60, 150 minutes of e-stim, or was it spread throughout the day? And if not, do you think completing the desired 60 minutes of electrical stimulation throughout the day would have the same effect?
So those were a whole lot of separate studies. So some of them did 45 minutes a day, some did 60 minutes a day, some did 90 minutes a day. And I think it's from memory that they pretty much were all done as like one session of 45 minutes or 60 minutes or 90 minutes. But I would have thought you could break that up too, and just, so maybe that's going to, and especially if you're really looking at somebody who's really trying to kind of work with the machine, then maybe it's going to make more sense sort of concentration wise for them to do 2 20-minute sessions or 2 30-minute sessions than one really long session.
There's a question here that we could spend an hour on, and I'll just say that it's a topic we're going to have a guest lecture that Carl will present on next year. Are there any interventions for people with high muscle tone?
Just get their weak muscles stronger. Forget about that. Forget about tone. So, I mean, work on the things that we can make a difference to, I think is the question there. And probably go back and really sort of look at your analysis but anyway, that is a very, very complex topic. But I think we also probably have to think about that. If we've said like probably something like 2/3 of our stroke survivors have very significant loss of strength, it's actually only about 1/3 of stroke survivors that really have spasticity. So loss of strength is probably a much, much bigger problem, and it's certainly something that we can really do something about. So I think, but where people really do have severe spasticity, but that's an extremely small number of stroke survivors, but where they do have severe spasticity to the point of really interfering with hygiene and things, then Botox probably is useful, but Botox doesn't improve function. So the thing, so we need to go back and address weak muscles and other impairments that can make a difference to function.
I'm going to let you continue on because we're already a little bit over time, and let you finish.
Okay, so we've looked at possible interventions for muscles that have less than anti-gravity strength, if you like. So now we're looking at grades 3 and 4. So muscles that can move against gravity, but still, don't have normal amounts of strength. So the main principles probably really are to start increasing the load. So you might, if you're doing isolated strength, increase the load of that. But if you're doing task practice, increase the load. Lower heights of sit to stand, more weight on the affected leg during sit to stand. Thinking about your upper limb practice, how you might start to increase the load. We can probably, if we think about the principles that were driving the practice of very, very weak muscles, the 0s to 2s, it was about very, very high numbers of reps with very low load, because you need to decrease the load so that the muscle can do more. Whereas now, with 3s and 4s, maybe you can start to think about higher load and maybe decreased reps if you're thinking about it in the context of strength. So I was thinking about more things that might look a bit more like progressive resistance training as an example. Okay, but if we have a look at progressive resistance training, which I have done in great detail, here's a systematic review looking at the effect of progressive resistance training. So what we did in this systematic review was take studies that had really followed like the American College of Sports Medicine guidelines. So at least 10 to 15 repetitions maximum, 2 to 3 sets, 2 to 3 times a week, continually progressed, so that it really was always that, at least that 10 to 15 RM. And remember, that means a load that you can only, if it's 10 RM, you can only move that load 10 times. You cannot do number 11. So real, so we only looked at the studies that in fact really did that progressive resistance training kind of dosage. Which means that you have to at least have probably grade 3 or grade 4. And even grade 3, you can probably only really do that within the mid-range of the muscle if it's grade 3. Grade 4, you can push into resistance. So you really can do progressive resistance training. It makes a big difference to weak muscles after stroke. So if you look at this pooled result, the effect size is 1, which is a large effect size. But what it actually represented in the muscles that were trained was a 50% increase in strength. That's a pretty significant increase in strength. I don't think you or I could really quickly get a 50% increase in strength, but it's a bigger increase because they're starting from a much lower sort of baseline too. However, if you have a look at so this is still the systematic review that I did, the effect of progressive resistance training on activity is not significant. So if we go back and think about that graph, now we're talking about muscles that are stronger. So they haven't got such a direct, relationship between strength and activity. So if you're a little bit stronger, that relationship has dropped off. So now you actually need to start to address the other impairments, which is really primarily loss of coordination. So if you only just do pure, and this is because this is progressive resistance training in these studies, it is very isolated strength training, like on Cybex machines and things like that, your classic strength training sort of stuff. If you want it to really help people improve their performance at the level of activity, now you really need to incorporate task-specific training as well. So as an example, here's a guy who, we're really working on him improving his push-off for stance phase of walking. And so he would probably really benefit from doing something like some progressive resistance training of his plantar flexors, because they still don't have normal strength in them. But if we only did the progressive resistance training without something that addresses his coordination problems, it's probably not really going to help his walking. So he needs to do some task-specific training. And when we think about task-specific training, remember, we need to think about reproducing the biomechanical demands of that task. So for this man, for his push-off, to increase his push-off in walking, we've set up a practice where we're really trying, so if you have a look at this, we're really trying to force him to get that concentric plantar flexion, that push-off at the end of stance while he's still in single stance on his weak leg. Because push off happens while you're still in single stance. And he's managing to do that. So this is his task specific practice. So maybe ideally for this man, he'd be doing some progressive resistance training for his plantar flexors plus some task specific practice. For this man, he's doing some sit to stand. And so he's doing some sit to stand with a weight belt. And because sit to stand inherently has quite high strength demands, you can turn that into progressive resistance training. So that's being done here by adding weight to him, by putting a diver's belt, and adding weights in. So you could figure out, how much weight do you need to add in so that he can only do 10 or 15 sit to stands in a row. If we have a look at Joe here, so he's doing some upper limb practice. So then maybe there's a few things that you could tidy up a bit here to maybe try and limit his trunk movement a bit. But now that he's doing something practice like this, and we'll have a look at him a bit earlier in a minute, but you could think about starting to add in some practice where he is doing things that have a lot more weight than that little bell, so that maybe you actually start to have some more strengthening component, but within his task practice. But maybe he lifts a big jug of water and pours a big jug of water, so you've still got some quite high coordination demands there as well too. And then you could kind of measure, how full is it, and measure how that changes. And so he's got some feedback about how he's changing. The other thing I'm just adding in here is which I haven't really touched on yet, which is why I'm adding it in here, is that after stroke there's some specific, if I can say that word, characteristics of loss of strength after stroke, and we see them with Mr. Lee here. And if you have a look at the gestures his daughter's making, that'll give you some hints. So there's three, if you like, very specific characteristics to loss of strength after stroke. And we see it here. We see it here. And if you have a look at what the daughter's gesturing is kind of, go further, Dad, go further. He's meant to be trying to push down into that towel behind his knee. He is having a lot of trouble in the inner range of his quadriceps. And that is one of the characteristics of loss of strength after stroke, is really having a lot of trouble producing force within the inner range of the muscle. And we're all weaker in our inner range. I mean, that's sort of something that's about the kind of the overlapping sarcomeres and stuff. But that problem is much worse after stroke. So really think about that when you're thinking about your strengthening. Think about setting it up in a way that you're also really going to think about going into the inner range of the muscle. And that is probably one of the reasons why people really have an enormous amount of trouble with their knees, is getting that inner range there after stroke. So the other things that you see with Mr. Lee, and again, it's part of the gestures that you see his daughter doing, is this. She's asking him to try and hold the contraction. And he's having a lot of trouble trying to hold the contraction. So sustaining muscle force is often really quite problematic after stroke. So that's another thing that you can really think about in addressing strength problems. And the other thing that you notice with Mr. Lee is that it's all quite slow. For him to really engage his knee extensors and turn them on as much as he can, it's quite slow. So we really need to work on power, if you like, increasing the rate of force production as well. So I think those are just some things also to add into thinking about when we're thinking about strengthening muscles after stroke. So those are those three characteristics. There's decreased speed of force production, force in inner range, and the ability to sustain force. The other thing I just want to touch on, again, because I haven't touched on it yet, really is, well, we're talking about measurement in the context, but I think measurement in the context of really thinking about what's useful for us to measure. And what is useful for us to measure is things that help to guide our intervention. So I think in that context, for weak muscles, very weak muscles particularly, manual muscle testing is quite useful. But I wouldn't be suggesting that you necessarily go through and, have somebody sort of lie back while you do manual muscle tests on every muscle under the sun. And think about what information you need for intervention. So you kind of need to know, can this person switch this muscle on at all? Does it have a little bit of movement, but not against gravity? So great. That means that you can set up an environment where they can really move that muscle as much as they possibly can by getting rid of the weight and the friction and stuff. Can they move against gravity? But that's about all they can do. Okay, so how are you going to set up that? So I think those kind of levels of grades of strength are actually quite useful for helping to inform our intervention. But in some way, that's kind of a bit more important than just thinking about whether it's a 1 or a 2 or whatever. What information do we need to inform intervention? And what information is meaningful to the stroke survivor? And there will be, probably some quite big issues around strength that are meaningful to the stroke survivor. So, how much weight is on their leg during sit to stand? How much weight is on their leg in standing before their leg starts to collapse underneath them? I mean, there's going to be a bit of overlap with coordination, but those are often going to be, really, really related to how strong that leg is. So maybe there's some sort of measures there that can be really meaningful to the stroke survivor that can give them some idea about their change over time as well too. So you could only get 20 kilos onto your leg during sit to stand last week, and now you're getting 30 kilos. Wow, I get that leg has gotten a lot stronger. So what are sort of some of those kind of meaningful kind of measures of strength, which maybe a bit more meaningful than just pushing it into a dynamometer or something, for example. Any questions, says the owl? Have you got any questions? Are they questions in the chat, Annie, or are they?
No, there's nothing more to add, and we've still got 197 people hanging in there, even though we're a little bit over time.
We did. A couple of people have got off to brekkie or dinner or something, I think. But okay, so oh my gosh, we've got some case studies. So just to talk about strengthening dosages. So we saw Mr. Lee before, and you saw him on the tilt table. He's got this very, very weak leg, what we're going to have a bit of a look at is strengthening dosages. So across about 12 weeks of an inpatient stay, this is some of the exercises that Mr. Lee did, and this is the numbers. So we're getting into some fairly significant numbers there, and that's all things that targeted his knee extensors. I mean, obviously he did lots of other things, but just the things that would have made a difference to his knee extensors was those. And here he is at about the time of his discharge. So, and I think the important thing with Mr. Lee is that, you know, if he hadn't done hundreds and thousands of strengthening exercises, he would not be weight bearing on his left leg sufficiently to allow him to walk independently and unaided as he is. So I think it really takes high dosages of practice to change a really weak leg. This is Brian out of one of Brian Bay's blogs. And Brian, I can't remember the length of stay that he had, but during his length of stay, he's added up from his practice sheets. 25,000 sit to stands, 130, oh my God, 130,000. So that's that sliding, his reps on the tilt machine. He's talking about the sliding, just pushing on the sliding tilt table. That might be plantar flexor strengthening as well as quad strengthening there. So he literally had 0 out of 5 strength through his right leg initially after his stroke. He now walks 12 to 15 kilometers a day. So he goes for 3 walks every day, and each walk is getting up around between 3 and 5 kilometers. So he's, you know, and that's unaided walking out around his community. So he's made some extraordinary differences to the strength in his leg, but he's done some extraordinary amounts of practice. Here's Joe. So this is where his arm is usually much weaker than when we saw him picking up that bell. Okay, and what we have then is sort of kind of the records of a couple of weeks of practice for Joe. And so these are so if we just go back and just have a look at the strengthening exercises that he did. This is all the isolated strengthening exercises. These are the numbers that he's done of those exercises. Then he's done, you know, a stack of task practice as well. And that's the numbers of those. Oh, sorry, that's not the right number. I might have done a bit too much copying and pasting there, I think. And so here he is 2 weeks later. So you can see he's really significantly different in what he's doing with his arm there after having done all that work. So the strengthening exercises is about 2,500. It is all semi-supervised. And so what I mean by semi-supervised practice, we'll have a look at Joe, is he's been set up to practice by himself in the gym. There is no therapist hanging out with him. He's been set up to do that practice. I mean, obviously it could be a little bit more better, if you like. It could be, we have something maybe in a chair, so he's got some indication to not move his trunk so much, for example, but he's practicing by himself. And here we see him, I'll just pause him here. Here we see him in the arm group. Again, maybe, you know, maybe a bit more sort of cues as to not use his trunk so much, but his practice is an arm group. He is practicing by himself, like this guy up here, practicing by himself. So you know, there's no way you're going to get hundreds or thousands of repetitions if people's practice is just one-to-one with a therapist. So looking at semi-supervised, people practicing in our therapy areas, practicing in groups. So not one-to-one with a therapist. Here's Ostea. She's walking at 0.2 meters per second. And you can see she's got some pretty significant problems with her left leg there. And then we have her week 1 of practice. We have 2 weeks of practice here. And this is all the strengthening exercises she does, about 4,000 reps in total. And this is the task practice that she does, about 2,500 reps of various task practice kind of reps. Week 2, again, a big dose of strengthening exercises, big dose of task-specific exercises. And if we summarize that across those 2 weeks, she's done almost 9,000 strengthening exercises. All the strengthening exercises that she's done are semi-supervised, as in she has done them in the physio gym. The physio might have helped set up the exercise, but the physio has then walked away. She's done the exercise by herself in that therapy space. Task training, again, about 8,000 reps, and over 90% of the task practice that she did was semi-supervised. And in fact, the only task practice that she did where a physio stayed with her was when that was needed for safety. So, so we need to really, to get high numbers, people need to be doing semi-supervised in an inpatient context. They need to be doing lots and lots of semi-supervised practice. And here she is 2 weeks later. So she's 4 times faster. She's at 0.8 meters per second instead of 0.2, and she's now walking independently. So you can see she's had some very significant changes in her strength in that left leg. But there's been a lot of work behind that. Okay, so let's have a little summary there. So if we think about the principles of strengthening in our very weak muscles, it's really low load, high repetitions. We need to increase the central drive, the activation capacity. So we need training that allows for lots and lots of repetitions of practice. Weak muscles are other grades. We can think about the principles, more the principles of progressive resistance training. So add in much greater loads that do address activation capacity, but also hypertrophy. But remember, if you're just doing plain PRT, you need task training to address coordination problems. Or maybe you can try and combine it together. So like we saw with that man doing sit to stand with a weight belt, for example. So have you got new things to add there? I'm hoping that maybe you might have some new things. There's some new things to add to your list of what you can do to across those different kind of levels of strength, if you like. So I might just flick through this because I know there's a few more questions, but so I'm just going to flick through to the summary and then any other questions. So in summary, strength is really essential for function. If you can't produce force in your muscles, you can't move, so it's absolutely critical. It's severely impaired after stroke. Particularly, it's the lower limb and upper limb muscles. If you're worrying about the trunk, do not worry about the trunk and come back and listen to Carl's lecture next week. Walking, all major muscles are important. The more disabled somebody is, the more strength is critical, and strengthening is critical. Repetitive practice. We need supervised independent modes of practice because people need to do high dosages of practice. Again, as muscles get stronger, you can think more about those progressive resistance training principles, but also make sure that you address coordination problems. So also you have task training as well. Okay, so, well, questions. Are there questions, Annie?
Simone, I think we have to finish because it's half an hour over time, but if you could put your reference list up on the screen so that anybody who's still online can view that. Carl's answered a couple of questions in the chat.
Thank you. You can't. Yeah. There's actually 3 slides. So if you want the references, take a quick screenshot. Have you got a screenshot of that one? That's first one, second one, and third one.
Okay.
Okay. So, well, thank you very much to everybody.